Health governance seeks to prevent disease but also, if it occurs, to make available to the patient as much medical and care technology as possible to treat the condition. If we understand as part of that goal to prolong life, it can be concluded that there has been an outstanding achievement. Life expectancy at birth is currently 73 years, and in 1960 it was only 53. This means in 60 years we have gained 20 years of longevity, a great success for humanity. From the perspective of mortality, which measures the probability that a 15-year-old person will die before turning 60, currently, 121 women out of every 1,000 have that probability, and 178 men, an appreciable difference in mortality between the two sexes. The governance book brings some data on morbidity, or diseases that a population suffers, so we invite you to take a look, in case the topic interests you. Health governance has three fundamental objectives: health promotion, healthcare, and health financing. In terms of promotion, there are some general recommendations about good habits. These are diet, hygiene, sleep, and exercise. These habits belong to each individual's intimate orbit, but governance can help to promote them. On the other hand, health governance is also concerned with monitoring food and medicine production since it can be a source of disease. One of the main goals of health promotion is nutrition. This is the food intake considered in relation to the caloric needs of the human body. Humans need to consume nutrients and micronutrients. There are 6 types of nutrients: carbohydrates, proteins, fats, vitamins, minerals, and water. Among these, vitamins and minerals are micronutrients, which are mainly found in fruits and vegetables. The Food and Agriculture Organization of the United Nations estimates that 1 in 10 people doesn't consume enough food to meet their caloric needs continuously. They consider that when there is micronutrient deficiency, we have hidden hunger because it manifests at the cellular level and, therefore, is not very evident for humans. In addition to promoting good habits and nutrition, and monitoring and controlling food and drug production, governance has an additional agenda around public health. This agenda has several elements. Let's highlight 4. First, research around diseases, treatments, etc. Second, the establishment of standards. Third, monitoring epidemiology, what diseases are affecting people. And fourth, a warning system to prevent public health emergencies. All these elements showed their relevance during the COVID pandemic. Regarding healthcare, this social service is organized according to the level of complexity. Primary care is a first personal and outpatient contact and doesn't require hospitalization. This service can be scheduled, priority or emergency. Preventive treatments such as vaccines, prenatal diagnoses, and children's development controls are also carried out at this level. The secondary level involves hospitalization or overnight stay at the care facility for a short time to take care of a more severe illness or injury. It's usually done in a hospital emergency room and, eventually, in an intensive care unit. But this level also includes scheduled care such as birth deliveries and diagnostic imaging. This level usually requires a referral from primary care. Finally, tertiary care has a specialized nature, where the person referred from primary or secondary care is admitted to a hospital unit for an indeterminate time. Let's finish with some important World Healthcare stats. There are, on average, 1.5 doctors, 3.1 nurses or midwives, and 2.7 hospital beds per 1,000 people. We have 30 surgeons per 100,000 population. 85% of children are vaccinated against DPT, measles, and hepatitis. 86% of women are cared for by specialized personnel at least once during pregnancy. 80% of births are attended by qualified personnel. And about half of women between the ages of 15 and 49, or their sexual partners, use modern methods of contraception. Perhaps healthcare governance's primary concern is financing. It is the question of who pays for healthcare. Healthcare is one of those services we don't want unsatisfied demand. But how does the health market work? When someone needs care because of an illness or an injury, most people don't pay the costs of that care out of pocket. Instead, people have previously bought an insurance policy covering the risk of getting sick. This mechanism is often referred to as prepaid medicine. Some minor health expenditures are not subject to risk, such as vaccines, child development checks, etc. But the bulk of healthcare works around covering the risk of getting sick or injured. However, any insurance market suffers from the failure of asymmetric information. In the case of healthcare, it means that policy beneficiaries know better about their health than insurance providers. Therefore, people who know are more prone to get sick will be more likely to buy insurance and make more claims. This will increase policy premiums, generating more unsatisfied demand for this service, which is not desirable. Healthcare governance has discovered that a way to solve this dilemma is to force universal coverage, partially or fully funded with public resources. When beneficiaries have to pay, in part or in full, the value of the insurance policy looks more like a quasi-tax. Moreover, once the premium is paid, the need to pay additional amounts for specific treatments often persists. These out-of-pocket expenses in healthcare are also part of governance concerns. A group of organizations has developed the Universal Health Coverage Index, or UHC. This indicator takes values from 0 to 100, being 100 perfect coverage. However, it doesn't represent a percentage. We find our sample of countries in the graph, with Canada at the top. The countries that we perceived as prosperous have UHCs higher than 80 points. Among the worst evaluated are Ethiopia and Nigeria. The average world UHC score is 64, with most of our countries above that average. The regional information shows the OECD and the European Union with the best UHC. At the bottom is Sub-Saharan Africa. The time series presents the out-of-pocket expenses compared to the total expenditures in health, both in dollars per capita. It covers almost 2 decades. We observe that both total costs in blue and out-of-pocket expenses in orange have grown steadily, being the latter a constant proportion of the former.